Okay, welcome everyone to this session in the afternoon. Hopefully your lunch is not going to send you off to sleep. We're going to keep you awake with some interesting content in this session. So we're covering two topics really in this session. My name is Dan Blackman. I'm an interventional cardiologist from Leeds, and you'll see that we have a stellar faculty. My colleague and friend from Oxford, Raj Kabanda, our discussants are Arif Kokar, currently in Copenhagen, Wolfgang Rottbauer from Ulm, Helga Mullmann from Dortmund, and Stefan Togweiler from Lucerne. In the first half of this session, we're going to talk about cerebral embolic protection. We've seen some big data come out recently, including earlier today with the meta-analysis of protected TAVI and BHF Protect, and we'll talk about those data and where we think cerebral embolic protection sits now. And then in the second half, we'll switch to a focus on the ACURATE platform, and we'll discuss the recent data. And we'll talk about where we go with ACURATE, what the future holds, how we should be using this valve platform today. So this is our outline, and without further ado, I think I'll move on to Raj. But as Raj comes to the podium, let me just remind you to try and get involved in this session. There's a whole line of microphones down the middle aisle of the room, but you can also interact through the app. If you put any questions on the app, they'll come up. Raj, as spokesperson, will deal with those, and we'll discuss those on the panel. We've got loads of time for discussion in this session. So I hope you enjoy this. Stay with us. Get involved. Raj, over to you.
Thank you very much. Thank you for coming. So some of you might have been at the session earlier where we presented this. My name is Raj Karbanda. I'm from Oxford. So I think there are three important questions. Is stroke still an issue in TAVI? What does the data tell us now, and how does it inform our practice, and where are we going to go? Any of us that do TAVI, and when we do that and a patient has a stroke, it's a devastating outcome. It's unpredictable, and it still remains an issue. Despite TAVI having got better and safer, unpredictable stroke is still an issue. And the majority of those strokes are thromboembolic. The vast majority occur within the first 24 hours of the procedure. So there is an ongoing need to address this issue. The Sentinel cerebral embolic protection device is currently the most widely available device that is in clinical use. And the two randomized trials that have tested this have both used a strategy of unselected, routine use. Protected TAVI, you'll remember, was 3,000 patients. BHF Protect TAVI was 7,594 patients. And here you see the primary outcomes reported for those trials, with both the number of events and also the proportion of disabling stroke. So these reported trials were neutral, but we've got now data on over 10,000 patients. How did these trials differ? You know, one of the things that people are interested in is how were these different? Well, I think like all trials, they're powered at the time that they're designed, and the powering was different. I think it's important to recognize that how accurately randomized trials reflect routine clinical care. And there's always a selection process. That's true of all randomized trials. In protected TAVI, it was a small proportion across those 51 sites. In BHF Protect TAVI, we really wanted to try and make this reflect routine clinical care as much as possible. And 30%, 1/3 of all clinical cases were enrolled. So it's a different population that we're testing. There were differences in the requirements for head and neck assessment. We were a pragmatic trial. You know, we were clinicians. We looked at the CTs. We felt we could deliver the device. And if we could, the patients were enrolled. And ours was a clinical stroke definition. So it was very much persisting neurology, prompted a stroke assessment. So there are some subtle differences that, you know, impact on the interpretation, which we can discuss. But these are the headline figures from the meta-analysis. So 2.3% with control, 2.2% for all stroke. And then on the right is the disabling stroke component, 1.3 versus 1% with a p-value of 0.09. And that's in the intention to treat the overall population. We then come to this more complicated secondary analysis. there's been lots of discussion. So remember, the modified intention to treat treats the population. We know that not all patients had the device for the duration of the procedure with both filters, and that's the per protocol definition that we used. Now, the case analysis is the complier average causal effect analysis. It's a new statistical method for many of us in this room, but essentially it maintains randomization and allows you to try and make some judgment about whether the non-compliance was relevant in this group. And using that analysis, there's a neutral effect of the trial. On the per protocol effect, however, which excludes those patients who didn't have both filters for the duration of the procedure, there is a numerical and statistically significant reduction. And when you adjust, you lose some of that power, but you are still significant. So the adjusted analysis looks like there's a signal for disabling stroke. So overall, as a routine strategy, there's no convincing evidence for a reduction in stroke. If we use the case analysis, we can't show a reduction, although the point estimates are to the left. And the per protocol gives us this tantalizing signal that perhaps disabling stroke may be reduced in that subset of patients. I think where we're going is to try and develop a prediction risk model. Routine use doesn't work. We need to know which patients are at higher risk. Should I use the device in that group, especially focused on disabling stroke, and exploring patient subgroups and other factors. And many of you may not have seen this extra analysis from protected TAVR, which looked at the US cohort outcomes versus the non-US outcome cohorts. And the US cohort seemed to have a statistically significant reduction in stroke with the use of the embolic protection device, about 2,000 patients as you can see there. And so there are some messages that we perhaps need to understand if it's effective. So in summary, I think stroke remains an important complication, and we all need to be respectful of that. It's not gone away, and it's impactful. I think the embolic protection strategy is intuitive, and randomized trials testing routine strategy so far have been neutral. And we really need to identify which patients are at higher risk and whether Sentinel is effective in that cohort. So I think that's where we are at the moment. Thank you.
Raj, great. Thanks so much. That was a superb summary of some fairly complex data that we'll maybe dig into a bit later. But before we get into the discussion phase, let's hear, having heard about randomized trials, how about Sentinel in a real-life scenario with high-volume use? So we're going to invite Wolfgang Rottbauer to tell us about his experience of using Sentinel routinely, I believe, in a high-volume centre. Wolfgang.
Hello to everybody, and thanks for the kind introduction. And I want to show you now some data or an opinion and reasons to continue in cerebral embolic protection, maybe on a center-based level. This is the outline of my talk, and I would like to ask the auditorium who will continue with cerebral embolic protection in a center after we have just heard the talk. You might raise your hands.
We're going to have a poll. We're going to have a poll question.
I know it will be later, but I just wanted to see it. So there are a lot of people that have to be convinced. So let's try it. So I want to show you first registry data, not randomized data, because you have seen that, and this was not very convincing. But everybody knows TVT registry data, and the last publication it was in 24. And what you see there is that only 30% of the US centers are using cerebral embolic protection devices on a routine use, but only 12% of overall TAVR patients are protected right now in the real world. But what does that mean? And this is just a highlight out of the results in the TVT registry with over 400,000 people included. You see a significant reduction of disabling stroke by using embolic protection devices. And what they show in the paper too is that there is certainly one established risk factor for stroke in TAVR, And this is the population that has a prior stroke already in the history, in the medical history, and they have a 4 to 5-fold risk for stroke. And they calculate even a number to treat of 155 patients. And you could stick to that and say, maybe I start my program again because I could prevent, especially in this population, maybe disabling stroke. Then I want to move on to my own center. So we started very early in 2015 or 16 with systematic protection in our TAVR population. And we got some data that we can prevent not overall stroke, but disabling stroke. We combined that, and these are all publications, and confirmed our results that there's always a dramatic effect on disabling stroke, although disabling stroke is a very rare event in the TAVR program, but a very significant one. And now I want to show you unpublished data. So coming from our old data, we continued on being on standard of care in a TAVR program that's doing around 500 to 800 TAVRs per year. And I'm showing you 2,500 consecutively protected patients. And everybody had to go into the protection arm and with the TAVR. And what you see is that 13% of our population were not eligible for cerebral embolic protection, either because CT scanning showed exclusion criteria such as stenosis or severe tortuosity, or we weren't able to access right radial or right brachial arteries in these patients. So we had then in the end a population of 328 unprotected patients and over 2,000 protected ones, and I show the result. And what you see here, again, a highly statistically significant difference now in the protected versus unprotected population in disabling stroke. And this is not a randomized trial, but what does it give us as a new information? You see in the gray box down there the characteristics of the patients where we couldn't achieve cerebral embolic protection. And there were more females in that group. They had a higher SDS score, and they had a much higher prior stroke rate already, 16% versus 11% in the patients that were eligible for cerebral embolic protection. And that is my take-home message from our own data. Patients who could not receive cerebral embolic protection were found to have a higher a priori interventional risk. So these might be the patients that might benefit the most from it. They have a higher rate of in-hospital disabling stroke and a higher peri-procedural mortality. With this, I'm going to my third reason, and everybody has seen that. I'm showing you an 82-year-old male with severe aortic stenosis, a lot of calcium, prior stroke, peripheral artery disease. And I raised the question, would you protect this patient? And I think nobody would do it in the room so far. And I'm showing you an angio, and you like to see that. This is really severely calcified aortic stenosis. And what does that mean? We had to predilate with a smaller balloon. We continue with a bigger balloon. And then in the end, we put in an evolute valve, 29, in that patient, and we had to post-dilate on that patient. So a lot of manipulation. And we decided, and you're not surprised, on cerebral embolic protection with the Sentinel. And I'm just taking a picture of the distal filter, but the same was true to the proximal. There was a lot of debris in the filter, and this is just emotion. I know it's not real data, but I don't want to have that in my patient's brain. So, and with this, I think I'm ready to end. There is always worth preventing stroke in TAVR patients, and this is not fun. The yellow press, you would say in Germany, is the Bild-Zeitung, and the Bild-Zeitung is picking up on a regular basis complication rates in TAVR and German TAVR centers, stroke rates, and mortality rates, and you can expect we're almost, otherwise I wouldn't have shown it, but I will end with that. Thank you for your attention.
Okay, that's great. So can we bring the poll up? We have an audience poll that we're going to use just to kick off our discussion. So this is a question that we want you to answer through the app. So fire your apps up. Following the results of Protected TAVR and the BHF Protect TAVI trials, and now the meta-analysis, what will be following those trials your current use of CEP? So we're wanting most cases, most or all, which is more than 80%, selected cases, which is a broad range, 15 to 80, very occasionally, maybe for those patients with intracardiac thrombus or mobile atheroma in the arch, or never or almost never. So we'll give you a little bit of time for those votes to feed through. While we do that, Raj, maybe I can come to you first. It's confusing having a modified intention to treat per protocol, and then we've got this case. So people might look at the per protocol analysis and say, okay, as long as you get both devices in, then you do reduce the risk of stroke. But it's not as simple as that, right? That doesn't necessarily mean that. Can you explain why the positive per protocol still doesn't necessarily mean that the device prevents stroke?
Wolfgang has done my job for me. You know, the patients who you can't deliver it in, either because of complex anatomy, that they're more female, they've got peripheral vascular disease, those complex patients are clearly at a higher risk of stroke events. And what the per protocol does is to disconnect your control group, so that it's a non-randomized group, because you take out these high-risk people, and so you lower the risk. And that's the statistical method. That's the reason that we need to be cautious. And, you know, as interventionists, we're very used to understanding the per protocol. And we think, you know, clearly, if you can get the device in, it works. But there is selection in whom you can deliver the device in, and trying to deliver the device itself in certain situations may cause events. So that's the balance that we lose with our, you know, conventional approach. And in device trials, the additional problem is all of the movement is one way, because the control group, you know, they don't get devices. So 16% of the treatment group get taken out. So you've got an unparalleled randomization. What the case does is it's a method of trying to maintain the randomization and adjust for that non-adherence. So that's why per protocol is difficult with device trials with one-way shift. But your data, it really reassures me.
Shows
that,
the same thing.
Yeah,
really
it shows the same thing, that if you can't get the device in, you're in trouble. But whether the group that you could get the device in, whether you randomize those, that's the question.
Yeah. So this is great. So, I mean, so just to clarify that, you can lower the risk of stroke just by excluding the patients in the treatment arm where you couldn't get the device in because they're at more risk of stroke. Yeah. And you selected a low risk population. It makes sense, but maybe they're, you know, but that's part of the story. We don't know how much of it.
Exactly.
Some of it might be benefit.
Exactly.
Okay, so we've got our audience vote in, and I think they're a bit more enthusiastic about cerebral protection than I was expecting. We've got the kind of highest vote for selected cases only, at least 15%, 45%, and only 19% in the never or almost never camp. So I think, Wolfgang, I think you managed to achieve something there with persuading our audience, despite that last bit, which we thought was an argument against. Okay, maybe before I go on to the question I've got for Stefan, Wolfgang, you and Raj both talked about using it in selected cases, and we used to do what you did. Before we were in the trial, we used Sentinel in patients who'd had a previous stroke, because almost every study shows they're at increased risk of a stroke. But the trials don't show that they are a group who have increased benefit from cerebral protection. So they are at increased risk of stroke, but that doesn't mean they're going to benefit from cerebral protection. At least that's what the trials... We haven't got the subgroup analysis yet from BHF Protect, but from Protected TAVR, the previous stroke didn't predict benefit from the device. So do you think we're going to find a group of patients where we can say there's more benefit?
Yeah, I think in the end we have to, because I think we have the data that disabling stroke numbers are decreased. So it's just a matter of statistics and power of the studies. So if you would not power for all strokes, but rather disabling stroke, I think it's calculated over 100,000 people that would have to be randomized. And I think, and I'm kind of happy about the public voting here. but I think, and this is why we are using still a cerebral embolic protection in all the patients, is how do you select the right ones? And what we learned is do not select, because if you try to select, you can either not accomplish protection, or you are protecting a patient or you're not protecting a patient that is still at the risk for disabling stroke, because it's just a trend. So regarding comorbidities, that gives you the risk.
Okay, that's fair enough. Stefan, you want to come in with a comment?
Yeah, just a quick comment. So we have also used the device about 700 times now, and we get exactly the same results as you. When we look at our data, again, not randomized, the group that didn't get the device has about 4 or 5% stroke rate, and those who get it, 1.5 or 2%. But again, I think your talk made it very clear that this is not the same. These are not the same patients. These are sicker patients. However, what we also do, we record the amount of debris from the first case prospectively, semi-quantitative, non-mild and massive or a lot. And this correlates with the severity of calcification of the aortic valve. So based on that, I would suggest, and based on these results as well, that probably in the heavy calcified patients, the one you showed, we can have a sweet spot where we have a reasonable number needed to treat to prevent a stroke, because these patients do have higher risk of strokes.
And Raj, am I right that you're going to be looking at the CTs in BHF Protect?
We're trying to look, yeah, exactly. We're trying to look at those and look at that. But I think it's going to be more complex. I'd love to say it's going to be one thing. And we've got, questions like, is it procedure time? Is it calcium score? Remember, procedure time is a post-randomization thing. You don't know how complicated it's going to be until you start. And that's part of the thing, that there are factors that fall out. You start the procedure, the valve embolizes, the coronaries occlude, it's a different procedure to a half an hour procedure in a low-risk patient with no tortuosity. And those factors are post-randomization. Now, in answer to the question, I suspect we are going to get a risk score. I suspect it's going to be a combination of factors. And remember, all the ones that we pick out, we say, is it bicuspid? Is it valve in valve? But it's a combination, if you're peripheral vascular disease, older, female, it's like the Euro score. It's like your surgical risk score. That's the best predictor.
But even what makes it even more complex is that with the device, we prevent the intraprocedural strokes.
Yeah.
Only those. We don't prevent the new onset AFib thrombus formation at day 1 and strokes. We don't prevent that. So we cannot use the traditional stroke risk factors to identify which patient will benefit the most.
And even if we identify that group, then we get into the cost effectiveness, right?
Yeah.
Yes.
So an NT of 155 in the UK, that means we'll have to spend about £200,000 to prevent a stroke. And the threshold for the NHS paying is £20,000 to £30,000 for a quality life year. So I'm not sure we'd get to that. But can I just go ahead, Ross?
I mean, stroke is expensive. We don't, the thing is, we treat the patients, we see them, but stroke is hugely resource expensive in terms of length of stay, in terms of care requirements. So we're going to look at that in the trial. We're going to actually have information on the cost of disabling stroke to society and in terms of quality of life. And I think that's crucial. We sit here, how many of us can say, the impact of these strokes is much larger than I think we necessarily recognise.
Helga.
Go ahead.
Let me just bring Helga in. So, because there's a couple of key questions I think we want to try and nail down for the audience. And they're not easy ones. But Helga, does the Sentinel have a future? This specific device?
Only if we have such a calculation mode to find patients at risk. So at the moment we have to treat all patients or 0 patients. And for me, it's more or less 0, to be honest. But if we would have this risk calculator, of course I would start again, no question.
So that's the key. And that brings me on to another question, Stefan, which I'll address to you, which is, what about cerebral embolic protection in general? Do you look at that per protocol and think, okay, well, I just need a device where we can get it protecting both vessels, or maybe even all of the vessels, because we don't protect all of the vessels with a Sentinel. or if we could protect all of the vessels all of the time with a radial approach, is that where we go? We just need a better device? What do you think?
Well, it's very hard. I mean, the strongest argument are these catch-of-the-day pictures. And they're so impressive when you see what's in the filter, and then you ask yourself, do you want that in the brain? No, nobody wants it in the brain. So this is really, I think if we had a deflector device, we couldn't look at what we catch. We would be easy. I would not have problems to give up the device completely. But since I saw quite a few cases where we had massive calcification in the filter, and since we see this correlation with the amount of calcification of the aortic valve, I'm still hanging on to the device. And I mean, the question is really, is it safe to deploy because you're directly interacting with the carotids and the trunk? And we don't do any sedation in our patients. And at least a major stroke we would detect, and we had never, during deployment, we never had a major stroke. However, we had one patient where we retrieved the device and the patient had a stroke. So probably at the, I don't know, like the edge of the filter, there was something that embolized when you retrieved the filter. So because I know for sure, I was talking to the patient, everything is good. We said we're finished. We take out the device and the patient is 10 seconds later has a stroke. But during deployment, we never had a problem. So I think if we have a device that covers the whole aorta, the SNE aorta, that would be something. There is now such a device available. But it's at the end of the day, as you said before, it's also a cost question. How much are we willing to invest in these devices? Probably not so much.
I just want to make one
more point.
I mean, I think it's really important that we use hard clinical endpoints. And, you know, Boston have to be congratulated for supporting these trials and actually focusing on hard clinical outcome trials. I think that's an important point to make because, you know, these pictures are great and we all have our own experiences. And yes, it makes sense, but let's see the clinical data.
I agree. Great discussion. Let's move forward to the second half then. So we're going to switch focus now to the ACURATE platform. And Stefan, we're going to start with you, giving us an overview of long-term outcomes with the ACURATE platform.
Yes, thanks, Dan. Okay, so I think we can all agree that the long-term outcomes become increasingly important as we are moving towards a younger and healthier patient population with a long life expectancy. These are my disclosures. So we have a 73-year-old woman. She has severe tricuspid aortic stenosis, calcified symptomatic stenosis. She has only coronary artery disease as comorbidity, otherwise healthy. Should we offer TAVI to this 73-year-old low-risk patient, or should we go for open heart surgery? So you can answer that question. I guess it's depending also a little bit where you live, how the access to TAVI is, and so on. But it's a fair question. This woman has maybe a life expectancy of 15 years. So we did go for TAVI because she absolutely refused to have surgery. We implant an ACURATE Prime with the all-in-one technique, as you can see. Now this is pre-dilatation. This is a true flow balloon that doesn't need rapid pacing, and then we implant the ACURATE Prime S in a good position. And there was also no need for post-dilatation. It was good expanded, and there was no leak. But still, the question remains, is it correct to implant an ACURATE, or should we use another platform where we have more data available? So these are the best studies, long-term studies for the SAPIEN 3, the partner 3, of course, on the left side, up to 5 years. And then we have EVOLUTE low risk on the right side, also up to 5 years. What you can see is that TAVI in both studies is non-inferior to surgery. And remember, TAVI does not need to be superior because it's so much less invasive. The patient will always prefer it. So if we are just as good as surgery, that's good enough. We don't have to be better. What we also see is that if you look at the partner study on death from any cause, initially TAVI is much better. But then at 2.5, 3 years, there is a crossover, and then there is a trend towards a higher mortality in the TAVI arm that is maybe going to be significant in future, maybe not. And this a little bit the same on the right side with EVOLUTE. Between year 4 and 5, you can see a catch-up in events. Initially, EVOLUTE TAVI was much better than surgery, but now it's pretty much the same. So again, we need to see 6, 7, 8, up to 10-year follow-up, which we will get from these studies. So ACURATE also has some longer-term data, and this is scope 1. If you remember, scope 1 randomized SAPIEN to ACURATE NEO, so the first generation ACURATE. And after 1 year, it was significantly better, SAPIEN. But after 3 years, again, you see this crossover, 2.5, 3 years, and they're both the same at 3 years in terms of all-cause death. Also the other endpoints. And if you look at valve deterioration, it's even a trend towards less deterioration compared to SAPIEN. So the 3-year results of scope 1 look actually very favorable for the ACURATE platform. We also have some longer-term data. Here is an older publication showing some patient with echo data up to 5 years. Only small number of patients, but it seems that the gradient is stable. And there is a recent publication looking at structural valve deterioration with the ACURATE NEO up to at least, let's say, 6 years. We have a low incidence of bioprosthetic valve failure. And then we have some data from Lucerne and also from Basel, because we started implanting the valve in 2015, so quite early. Some patients already have 10-year follow-up now. And in this slide, we try to, and it's unpublished, we try to replicate the US IDE trial by pooling EVOLUTE and SAPIEN and comparing it to ACURATE NEO or NEO 2. And you can see any stroke here, and honestly, I don't understand why, but we don't see this difference in stroke. Up to 8-year follow-up, that is, and survival is exactly the same. Now, of course, that's not a matched population. There is more women in the ACURATE arm because there is no, with the NEO and NEO 2, there is no big prosthesis and so on. So there is some differences here, but at least if I look at these graphics, it's for me is very convincing that we can use the ACURATE up to 8 years follow-up with a good result, same as SAPIEN and same as EVOLUTE. We also have some echo follow-up with more patients. At 5 years, we have about 150 patients now, and you can see again stable gradients. If at all, the gradients are actually a little bit lower. I don't know why that is, maybe a survivor selection bias, but also the aortic valve area, the opening area of the valve remains super stable. And then here, this is now pooled with Basel data. So 2 Swiss centers, we have again 8-year data. We can see the survival. Of course, at baseline, these patients were 82 years. So at 8 year, they are 90 years on mean age, so quite old. But still 36% are alive. If we look at the stroke, yes, there is quite a lot of strokes also, not only during the first year or the first 30 days, actually more so during long-term follow-up. We have 16% stroke rate at 8 years. The pacer rate is very low, very satisfying to see that. We have 7% at 1 year, and then at 8 years, only 15%. So the new pacer rate is about 1% per year in this population. And then structural valve deterioration. There were some events between 5 and 8 years. Most patients had actually a wear and tear, so transvalvular regurgitation. Only very little had a stenosis. So the mechanism of failure of the ACURATE seems to be more regurgitation than restenosis. But at least at 5 years, where we still have a lot of patients, it's 2%, which is really good. At 8 years, it was a little bit more, but the confidence intervals here are very wide because of the low number of patients. If the degeneration occurs, you need a plan B, and you actually have a plan B, and you can implant the SAPIEN or a balloon expandable valve in a degenerated ACURATE. We have done it a few times. It works really well. I think you have to repeat the CT and you perform a new measurement, and then based on this, on the ACURATE frame, you size your SAPIEN, because if you take the initial CT, you're maybe a little bit too aggressive with the sizing. So you do a new CT, you measure along the frame, and then you size your sapien valve. And you don't need to put it very high. You don't need to completely stand open the leaflets. You can have some overhang and it's still fine. And then we can also do the opposite, by the way. So if you have a degenerated sapien, here in this case it's a sapien XT, we can also implant an ACURATE, in this case an ACURATE Neo-M in a degenerated sapien XT 26 millimeter with a very good result. So both works. So in summary, I hope I was able to show you that the available evidence, of course we need more evidence, but we do have some long-term data now, up to 7-8 years, and we can for sure say the gradients, they remain low. The opening areas remain very high, around 2 square centimeters. If valve degeneration occurs, it's mainly wear and tear. So sometimes you have a flail of one of the 3 leaflets, and you can implant a balloon expandable valve in these patients with a good result. Thank you very much.
Thanks, Stefan. That's really great to see some real-world data. I mean, I think one of the things that does strike one about ACURATE is that there are a few potential strengths for lifetime management. I mean, Wolfgang, can I ask you, how do you see that with ACURATE? What do you see as its kind of strong points in terms of lifetime management, long-term outcomes in patients with long life expectancy?
So I think even if we are discussing long-term outcome, I think we should start with the immediate outcome. So with paravalvular leak, pacemaker implantation, because this affects long-term outcome. And I think we have to use things like that to discuss that point. And I think they're very convincing regarding the ACURATE platform, regarding paravalvular leak and pacemaker rate. So they are more on the lower side than on the higher side. We have other valve types, and I think this is very important. And then coronary access, for sure. This is one of the major points, and even maybe the supraannular design might be something for long-term outcome, as we have just seen. Is valve degeneration might be less frequent in a supraannular design than it might be seen in an intraannular design. And I think these are the key points I would raise on the ACURATE platform.
Yeah, no, I agree. And I mean, I think, although the US ID trial results were disappointing, it was noticeable that the PVL results, NEO2 had fixed the PVL that we saw with NEO1, right? Now we need Prime to fix those other issues. But for sure, I see the same thing as you, that we have a device here that has good hemodynamics, that has pretty much a very reliable technique for commissure alignment.
Lowest pacer rate in class.
Lowest pacemaker rate, big space to get back into the coronaries, easy retreatment with low risk of coronary obstruction. So definitely strengths for the long term, but we need the data, I guess, to show that this device can work just as well as the kind of best in class. When we talk about that, Raj, there's a session tomorrow which is going to spend a lot more time talking about the US ID trial and the data. So look out for that, and that's not our main focus today. But what about, are we seeing a discrepancy between the trial results and the real life outcomes in high volume centers? Because we know that in the trial, the sites did very small numbers of cases. It was like single digits per year that they were doing. And that's different to, we know with any platform that's different to when you're doing high volume all the time. Do you think there's something in that? Is there something about operator skill or experience or strategy that's particularly pertinent to ACURATE?
Well, there's a whole range of factors, aren't there? And randomized trials are important. And, we've discussed some of the complexities of randomized trials, but you need to confirm that data with what people do and how it performs in real life. And I think one of my points to the audience would be, if you've got national registries, please enter the data, because actually those are really important for us to actually surveil what's going on with these devices. And as, responsible physicians, we need to do that because, it's important that if there are issues with devices, they're picked up, but also to reassure our patients and to understand that. And I think your point is right about experience, volume. There are as I'm sure across the world, there are some centres that are large volume users of one valve type and another valve type. Now, that's driven by experience, and if there's a valve type I'm familiar with, I should be better at using that, and I shouldn't be doing my highest risk cases with a device that I'm not familiar with because it's right for that patient. So I think the point you make is right. But those are very difficult signals to pick out, because in the vast majority, most valves will do the trick, and that's a hard signal to pick out. But it speaks to the need for data.
Well, I think the other point, is that we've seen there are some data showing there's a discrepancy in the learning curve.
Yeah.
There's a nice registry that showed if you're a low volume SAPIEN user, you still get good results, the same as high volume. But if you look at evolute and put low volume operators, they're not getting the same outcomes as high volume operators. And some of the valve technologies do require more attention to detail, more experience to get good results. And that may be something that we saw about ACURATE. Time is short, so we're going to have to move on. But we've got another discussion section coming up. But as we touched on those issues from the US IDE trial, I'm sure you'll all be familiar with the biggest issue, which was under-expansion and the impact that had on clinical outcomes. So it's a real pleasure to have Arif here, who's done some expert bench work looking specifically at this issue of frame expansion across multiple TAVI platforms. So Arif, we look forward to seeing your findings.
Great, thank you. So it's my pleasure to talk to you today about under-expansion, but really using this unique methodological approach of bench testing. And hopefully I'll share with you some principles, but also some practical things that you can take back into the cath lab. So the first thing to mention is all the transcatheter valves that have been designed, the way they're designed, packed, and come out the packet, they're all supposed to be circular, well expanded, and achieving the nominal size. But we know that when we put these valves inside of patients, we always achieve some degree of underexpansion. So there's always some degree of underexpansion that we're having to deal with. The question is how much and when does it matter? Furthermore, we often now, particularly after the IDE trial, are talking about underexpansion as a binary phenomena. But it's not that you have it or you don't have it. There's clearly different patterns of underexpansion that can exist. So for example, you can have, let's say, a 29 diameter device, which you put it in the patient and it remains circular, but it's 25. So that would be concentric, but still circular underexpansion. Then you can have something which might become very elliptical, and naturally our normal annuli aren't actually perfectly circular anyway. And at what level of ellipticity does it matter? And then you've got what we saw more so in the IDE trial, this kind of regional or asymmetric underexpansion, sort of a very, let's say, calcified NCC pushing in onto the valve frame. And does that matter more? If we get the leaflets, it's very interesting. So on the left-hand side, we've got a well-expanded concentric valve. On the right, you've got the severe underexpansion. You can clearly see you've got a real restriction of the opening of the leaflets, which then gives you this reduced geometric area. You can have an impaired coaptation, and in certain circumstances, that sort of nice Mercedes-Benz sign that you have with a very central coaptation point, you can lose that, and that can become asymmetrical or off the center. If you just focus at the bottom right image, and I just want you to look at around 6, 7 o'clock, you can see that where that valve is pushed in, the belly of the leaflet, you develop these creases within the leaflets, which is different to pinwheeling. Pinwheeling is the sort of rolled up edges of the leaflets. But here you've really got these creases, which one of the hypotheses is that maybe these can act as a nidus for forming little thrombi, which can then cause events later on. Of course, the other question is, well, what degree of underexpansion becomes a problem? A little bit is probably okay. It doesn't affect the leaflets so much. A lot, clearly, you can have a big impact on the leaflets. And we're now trying to understand at what point, and more importantly, at what point that we can evaluate in the cath lab, does underexpansion likely to have an impact. We can look at hemodynamics. So on the left hand, we're going from left to right. We've got a well-expanded valve to severely underexpanded. And we're looking at transvalvular gradients. At low levels of underexpansion, you don't have that much of an impact on the transvalvular gradient. As you would expect, as you increase the amount of underexpansion, then your gradients start to go up. But something interesting is that you don't quite hit that VARC3 technical failure 20 millimeters of mercury mark. So what might that mean? Well, maybe gradients isn't really the hallmark to tell us that we have underexpansion. In other words, and maybe this will come out in the discussion later on, you implant your valve, good gradients, no PVL. Is that it? That might not mean that you do not also have underexpansion. And then, of course, it's a question and debate if we need to then chase that. We can also look at the flow patterns across the valve. So in blue, we've got well-expanded valves. In orange, you've got underexpansion. And you can see that in the underexpanded scenario, you've not only got increased velocity across the valve, but that also then translates into increased shear stress upon the leaflets, which again is then associated with formation of more thrombi. I show you this image. This is a normally expanded valve, concentric, circular. You've got that nice central jet, laminar flow, less shear stress. And if you look on the right-hand side, this is particle imaging. We can see the individual particles and how they flow in the sinus, and you get relatively good sinus washout. Now keep these images in mind and compare them here. This is now severe underexpansion. You've got a very turbulent jet, which can be eccentric. And particularly if you look on the right-hand side, you've got less washout in the sinuses. And this is this concept that some people have looked at with computer modeling or also in vitro studies of blood stasis time. So how long blood stays within the neosinuses. And perhaps this might be one pathophysiological link between what we're seeing in the trials and maybe what we're seeing here in vitro. So that's how underexpansion can impact things. Now, about evaluating it and some practical things, you're all familiar with these different patterns of how to evaluate underexpansion with the ACURATE platform. I want you to have a look at this in a different way. These two things, we're looking specifically at the stent frame, and here we're looking at the commissural posts. And this is an important point, that we have to understand the specific signature that the valve we're using has for underexpansion. So how can we identify underexpansion? So to give you an example, this is a circular, well-expanded, well-aligned ACURATE valve. You go to your 3-cusp view, the stent frame looks well-expanded. You then move the C-arm to the cusp overlap view, it looks well-expanded, and that makes sense. You have a circle, no matter which way around you look at it, everything's going to look the same size. Contrast that now, severely underexpanded, well-aligned ACURATE valve. You look in your 3-cusp view, often it may look okay. So when we're looking at that stent frame, it doesn't appear to be as underexpanded as if you come to the cusp overlap view, look into the minor axis, and that's when you'll see that stent frame is constricted. So the learning from this is that frame expansion, that particular signature, is best seen in the cusp overlap view with an aligned valve. Now remember, the other thing was the parallel posts. So if you have an aligned valve, you go to your cusp overlap view, you won't really understand how your posts are and the relationship to one another. It might seem okay. You swing across to the 3-cusp view, and that's where you can then assess the 3 posts, and you can understand that one of them is not parallel. So again, the parallel post in this scenario was best assessed in the 3-cusp view. And I use this to illustrate the point that it's clear that, particularly with this valve platform, we need multiple fluoroscopic projections to evaluate and then to confirm that we have frame underexpansion. And then we can go and do something about it. Of course, I think the principle of prevention is better than cure when it comes to underexpansion. So an effective pre-dilatation, done properly, right-sized balloon, and simple things, even again in the cath lab, switching over to RAO or going towards a cusp overlap view. You might see in the 3-cusp view the balloon looks fine, but if you do your pre-dilatation in another view, that's when you might see your indentation and then think, okay, I need to either repeat the pre-dil or take a different balloon. And then finally, just to end, we've got 2 valves, both underexpanded, both the same size. On the left-hand side, this is a post-dilatation with an 18 millimeter true balloon, and you can see as it inflates, it barely touches the edges of the valve. So you would tick that, yes, post-dilatation done, but is this an effective post-dilatation? Compare that now on the right-hand side, an appropriately selected postal balloon, and you can see you touch and then can actually impact the valve frame. And just to show that in a different way, same anatomy, same valve. You see the 18 balloon barely has an impact on the underexpansion of the valve. You take an appropriately sized post-dilatation balloon and you can really expand that valve. And because this is fundamentally nitinol technology, it will want to retain the shape that it's been, let's say, told to take. So finally, to conclude, then, underexpansion is not necessarily just a binary phenomena. There's obviously severity, there's different patterns that we can see. Has an impact upon the leaflets, blood flow, as well as some of the shear stresses, and this might give a link to why we are seeing what we're seeing in the trials. We have to be aware of the signature of valve underexpansion, and this is for whichever valve we're implanting, and often needing more than one fluoroscopic projection. And finally, cannot stress enough the importance of an effective pre- and post-dilatation. Thank you. Thank you.
Arif, thanks. Yeah, come and join us. So we've got a few minutes for discussion before our final talk. Stefan, Arif touched on some of this, but you're a high-volume ACURATE user. Walk us through your kind of best practice for treatment of patients with ACURATE in terms of pre-dilatation, sizing, post-dilatation, etc. What's the best way to use this valve?
Yeah, I think it starts with the patient selection. So based on these data, I would not use it in super heavily calcified. You can use like moderate to severe calcification, but if you have really super heavy calcified valve, I would not use it. Also, if you have a bicuspid with a calcified raphe, you will likely not be able to completely correct the underexpansion, and I would not use the valve for this indication at the moment. And then, as you have nicely shown, it's important to use a proper balloon for pre-dilatation, because the balloon will always go where the least resistance is. So if you take a small balloon, it just goes where there is no calcification or where the valve is already open for post-dilatation. So you need a good balloon to really modify the leaflets during pre-dilatation. And then the third point is selecting the valve size. In the past, we have tended to use, when in doubt, we use the bigger valve, the larger size. And that may not always be the best strategy, because of course if you have a very large valve, you may have a higher risk of being underexpanded. And then when it comes to the post-dilatation, again, you have to use, as nicely shown, you have to use a proper balloon, and you have to check for the underexpansion in 2 different views.
That's great. No, thank you. And I think, it's interesting. I think we're seeing a change across the board with self-expanding to more aggressive preparation, pre-dilatation with Navitor. We also move now to pre-dilating with a balloon equivalent to the primitive diameter.
Like PCI.
Definitely seeing a difference, yeah. Arif, quick question for you, because we are short of time. Is Prime going to fix the underexpansion?
Yeah, the extra cell that's been added is supposed to increase the radial strength, but the radial strength will come into play once the valve has been deployed, and then it will have its radial strength. Whether that's changed the opening force, which is the force you're pushing against, I don't know how much of an impact that is. So I think the principles of what we do as an operator would still apply more so than perhaps just the device. So selection, sizing, and then a good pre-dilatation.
Okay, that's great. Well, I think that leads us nicely into our next talk, which is on the future. So Helga's going to talk us through the planned clinical research pathway in TAVI with the ACURATE platform. Helga.
Dan, thank you very much. I'm not only talking about the future, I'm always also talking about what's going at the moment. What kind of research has been done to explain things, to bring the whole system forward. And I would like to start again with the same topic we just discussed, namely the mid-frame underexpansion. And I would like to shortly show you the results from Dr. Kim's work, who looked whether the underexpansion really has an impact on the clinical outcome. And you can see in the upper left panel, the primary endpoint, patients who had an underexpanded valve did much worse in comparison to those patients who had no underexpansion. In this group of patients, this mid-frame underexpansion was only represented in 9.4%. But these patients, these 9% of patients really had a bad outcome, and this had an effect on the overall population. And this is of really big importance, because the post-dilatation can solve the problem, as you can see on the lower left panel. If you post-dilate, there's a much better outcome in comparison to those patients who were not post-dilated when the valve frame is underexpanded. And the number needed to treat is 4. So this is an extremely low number, again highlighting the importance of this proper implantation technique with pre-dilatation and post-dilatation in order to guarantee a good primary outpoint. As you can see on the lower right panel, here there was no underexpansion, then there is no need, and then you have a really good result. I now come to the next trial, which has been published a couple of weeks ago. It's a trial from Andreas Ruck, who used the data of the Sweetheart registry in order to simulate similar trial, as has been seen in the IDE trial, based on the Swedish data. And everybody has in mind the IDE trial results, which were not so promising. Completely different if you apply the same principles on the patient of the Sweetheart registry. There is no difference whatsoever between ACURATE patients and patients who have been treated with SAPIEN or Evolute device. As you can see here, hazard ratio 0.97, absolutely parallel lines in this Kaplan-Meier curve. So there is a clear sign that a good experience with the device may be important in order to guarantee such nice results. And if we look into the different components, be it all-cause mortality on the left-hand side, heart failure hospitalization, right upper side, or stroke on the right lower side, there is no difference whatsoever. So everything which was found in the IDE trial could probably be avoided with a proper selection of the technique. And this taken together is here again, and you can see we have this absolutely parallel lines in the Kaplan-Meier analysis, no difference in death, stroke, or heart failure hospitalization. Again, a sign that we really have to take care what we should do. I would like to repeat some results which have been shown earlier today, and we are now coming to the ACURATE Prime valve. Here we have the first results from the ACURATE Prime registry, 30-day results. A lot of patients have been randomized, not randomized, enrolled into this study, 500 patients. And you can see here pre-dilatation 99%, post-dilatation 50%. So obviously there is some learning already that it is important to probably treat these patients. And if you apply this technique and if you use the ACURATE Prime, you can see there is a technical success of 98.6%, which is really a good result. And valve-related, directly valve-related, is only a minority. So the main point here was vascular intervention, which was necessary, and this cannot be associated with the valve itself. If we take the results at 30 days, perfect results, as you can see here, a very low rate of death, very low rate of PVL, and a acceptable rate on stroke and pacemaker implantation. What's going on or what's coming next? So there are a couple of clinical trials which already are confirmed. So we have the EuroPCR 25 will be shown tomorrow, the TAVI CEP trial at New York Valves in a couple of weeks. There will be the presentation of long-term outcomes after TAVI with this self-expanding prosthesis. We already saw a couple of data today. Then there is ongoing trials, double choice, proof registry, early prime. These data will be presented in the next couple of months or years, depending on the follow-up. And of course, there are more research plans which are important to really bring forward this technique. There is the ACURATE Enhanced trial, which tries to show that an optimized training is important. And there's probably a next clinical trial in the European Union. Here, the discussions are ongoing, and we really look forward to see what's coming next. Thank you very much.
I'm just going to wrap up. So firstly, thank you to the panel and thank you to the speakers. Really great session. I think we started with stroke and, we don't want to, it's still important. We need to understand where we're going to use this. That's the sort of messages I got. Modern TAVI, we're getting great data. We've got some really interesting data from registries looking now at long-term outcomes, which are important. And, this is 8-year outcome. This is really fruitful data. We need to understand these devices and showing these sorts of data are important, I think, for us as a community to learn about this. We've got this signal of underexpansion, so not only can we do it well, but we can do it even better, and we're beginning to get this signal of recognizing underexpansion, and then some very practical talks about how we recognize it and what we should do to it and the mechanisms behind it. And then this evolving data now, both for longer term data and for PRIME, and looking forward to the future to more randomized trial data coming out. So I think that's been a really good session. Thank you everybody for attending, and thank you to the speakers. Thank you.